Thank you very much, Peter. That was extremely generous of you. Thank you very much for having me here, and thank you for letting me share the floor with Dr. Kobilka. This is my first time to Hungary and Budapest. When I was growing up, I learned all about Ignaz Semmelweis and was very inspired by him. And so it's quite remarkable to be right opposite Semmelweis University. You have a beautiful country, and what strikes me is the level of optimism in this country, and that's really remarkable. So I'm hoping to learn even more during my stay here. So for some of you may not have been to Singapore. We are a tiny island city-state. We are smaller. The only other city I've lived in is Manhattan and New York City. So we're smaller than New York City and the 5 boroughs. We have less than 6 million people. We are a multi-ethnic society. There are more people who go through our airport than the number of people who live there. One advantage of Singapore, though, is that you can fly to most places in Asia, Australia, and a big part of the Middle East within one direct flight. And I liken this to New York to Los Angeles. The flying time is basically within 6-7 hours, you can cover a big part of the world. We're a very young country. We only became independent in 1965. You can see the similarities and the differences between Singapore and, of course, Hungary is a huge, you were the seat of a former empire. Hungary is already a super-aged country at more than 21% of the population over 65. Singapore will reach that very, very soon. So I'm going to spend my next 40 minutes or so describing the other historic change that the world is experiencing. And maybe a little bit about my background. I started my life, I'm a practicing hematologist, oncologist. I started working in tumor metastasis. Then I went into drug development. Then I helped form a cancer center. And then I was dean of the medical school. And then I slowly moved out from running clinical trials to starting looking at how can we take the knowledge that we have in science and medicine and really help this to benefit society. And what has struck me is that I'm not really sure whether everyone is aware of the other historic change that's happening that humanity has never experienced before. We all know about climate change. We feel it. We see it. But the other historic change that humanity has never experienced before is demographic change. And let me just sort of share what's happened. About 1900, a remarkable thing happened around the world. That life expectancy in 1900 shot from about maybe in the 30s, from the 20s to 30s to about 47. We almost doubled life expectancy between 1800 and 1900. But then between 1900 and now, we've again doubled life expectancy. So in Hungary, it's now 77 years. In Singapore, it's 85. And that's really remarkable. It's probably one of the biggest success stories of the 20th century. But why aren't we all celebrating? I think it's because at the same time that this has happened, global fertility rates around the world have dropped by 50%. I was giving this talk in Saudi Arabia this time last year, and the Saudis were telling me that they've gone from 7 children per family to 2 children per family within 1 generation. So even Saudi Arabia is below replacement rate. And in 2019, the curves crossed globally. So the world now has more people over the age of 65 than under 5. This is happening in nearly every society around the world. 2/3 of the world is now below replacement rate. Now, this could be good. It could be good because maybe we can actually focus more on sustainability. But I think it's important to discuss what the world is going to look like now that there are more people over 65 than under 5. How can we really appreciate every human being? And how can we really appreciate human capital, which is probably the most important capital any society has? The United Nations called the world's attention to this in 2017, where they said virtually every country in the world is experiencing demographic change, and that population aging is poised to be one of the most significant social transformations of the 21st century, with implications for nearly all sectors of society. So we all need to be prepared. What people may not be aware is the speed at which this is happening. So it took France 145 years to go from an aging to an aged to a super aged society. The United States is going to do it in 88 years. Hungary doing it in about 61 years. Japan did it in 36 years. Singapore is going to do it in 28 years. So when I was growing up, we went from a young country to an aging, to an aged, to a super aged, all within my lifetime. And it's this speed of change which is so profound that I don't think that people understand what this means. The speed of aging in Asia is the fastest of any continent, and it's primarily because Asia does not have the huge amounts of immigration that Europe and North America have. But if you look at 25 years' time, I sort of say 25 years is about the same time as 9/11 to now, or when the Berlin Wall came down to now. It's within living memory. In the 25 years' time, look at the countries listed here. In Hungary, more than every third person is going to be over 60. In Singapore, nearly every other person is going to be over 60. 6 of the 10 most aged countries in the world are European. Look at Spain. It's going to be nearly every other person over 60, and so on. And this change will affect everything from family structures to social infrastructure, insurance, housing, transportation, patterns and prevalence of chronic disease, healthcare delivery and financing, and even the workforce. So the United States released in 2019 that nearly 63% of non-interventional cardiologists in America are over 55. I didn't show the demographics of pulmonary physicians. In the United States, 91% of respiratory physicians in the United States are over 55. What does that mean? So the question is, are we prepared? And the bottom line is that there's very mixed levels of preparedness. There are very few countries which are prepared both for what this means to their society as well as seizing the opportunities. And I would like to spend this time talking about the opportunities which are awaiting societies, but it requires a huge amount of effort and investment. So why is everyone apprehensive to the point that no one really wants to talk about it? I think it's worthwhile going back to looking at definitions. And I think that many times we forget that health is a combination of 3 dimensions: physical, mental, and social well-being. You know, my whole life I've been spending my time working on physical well-being, controlling the risk factors for cancer, chronic disease, hypertension, diabetes, hyperlipidemia. I think over the last 15 years, the world is paying more attention to mental well-being, which is tremendous. But I honestly don't think we're paying enough attention to social well-being. And my work on the ground now tells me that social well-being is the key to the lock. Without social well-being, it's very hard to have mental and physical well-being. The US National Academy of Medicine has defined healthy longevity as the years in which good health approach biological lifespan, with physical, cognitive, and social functioning. Again, this whole issue of social functioning is so important that the US Surgeon General has basically called out the impact of loneliness, that loneliness confers morbidity and mortality equivalent to smoking 15 cigarettes a day in terms of affecting health. So we really need to preserve health for all, across all ages. I think it's worthwhile spending a little bit of time talking about both life expectancy and health-adjusted life expectancy. So life expectancy is basically the biological lifespan. But health-adjusted life expectancy is the years in which we spend in good health. And during the course of life, if there are periods of morbidity which require hospitalization, that robs us of that full lifespan. And what's worrisome is that the prevalence of chronic disease is increasing in younger populations. We're seeing a rising incidence of cancer in 30-year-olds. I mean, I have not seen colorectal cancer coming up in 30-year-olds like what we're seeing now. It's changing our recommendations. We don't start screening colonoscopy until 50, but yet we've got 30-year-olds coming down with colorectal cancer, let alone breast cancer and other cancers. And of course, the pediatricians are telling me they're seeing type 2 diabetes in 18-year-olds or 15-year-olds. So do we have healthy do we have healthy longevity? This is Singapore's lifespan and Hungary's lifespan. This is the gap. In Singapore, there's an 11-year gap. In Hungary, it's a 10-year gap. In nearly every society, the United States is about a 15-year age gap. In all our societies, there's this gap. And we have to close this gap. We have to close this gap if we are going to take advantage and benefit from the longevity dividend, that remarkable miracle of the 20th century that has been given us. We have not capitalized it, and in fact, we may be squandering it. So what's the current landscape? I mean, so this is data from Hungary, a significant degree of smoking, alcohol consumption is significant, obesity, poor diet. But this is similar in Singapore, too. Singapore, the prevalence of drinking has doubled. Binge drinking has gone up. Smoking, we're happy to say that at least the population, the youth are smoking less. That's good. But look at the prevalence of obesity, it's going up. And in Singapore, our prevalence of obesity is going up alarmingly in our Malay and Indian populations. What about chronic disease? This is stunning. In Singapore, 3/4 of people 70 and over have hypertension, of which 2/3 are poorly controlled. Nearly every other person in Singapore over 60 has hyperlipidemia, and diabetes, 1/4 of the population over 70, and of which, again, nearly 2/3 are poorly controlled. So we are not setting up the grounds for healthy longevity. In Hungary, I dare say the statistics are roughly similar. Cancer screening is abysmal. The Nordic countries are doing a much better job than Singapore, and I think Hungary also has gaps in terms of screening. And mental health. What's very worrisome is that the prevalence of poor mental health is rising. It's especially in our younger populations. In Singapore, females more than males. But the older population, less likely to seek help. So what can we do? The good news is that there is overwhelming evidence that we can narrow this gap, that you can have healthy life expectancy, match life expectancy. And these are the two probably most freely available comprehensive documents that I know, partly because, I was privileged to co-chair the document on the right. This was the first global grand challenge of the US National Academy of Medicine, where they had an international commission of 19 commissioners, and I was privileged to co-chair this. The document on the left is WHO's Decade of Healthy Aging, which came out in 2019. The NAM report came out in 2022, but this is free, you can download it, and it provides all the evidence up to 2022. There are probably three important concepts that I think that we need to share with everyone. The first is that health is the outcome of multiple determinants: social, economic, environmental, and structural. And just looking at social alone, there are at least 10 determinants, social determinants of health, of which the health system is just one of 10. So this was the diagram that changed probably the course of my career, because in 2007, the Shattuck Lecture in the New England Journal of Medicine by Steve Schroeder from UCSF, Dr. Schroeder said, healthcare, all of us working in healthcare, we can only shift the needle in about 10%. And, like everyone in this room, I've been working 80 to 100-hour weeks. And I was thinking, my goodness, I kill myself and I can only shift the needle in 10%. I need to get out into that green zone, because 2/3 of the factors that impact premature disability and premature death are social, behavioral, and environmental. And even my colleagues, or even people working in shaping the physical environment, housing, transportation, their impact is double that of healthcare. And we know that the phenotype is very often influenced by the environment, that if you have a supportive environment, you can have genetic deficiencies which can be heavily modified. So what are some examples of social determinants of health? This is from the United Kingdom, 2018 data. If you are living in the United Kingdom and you want to eat a healthy diet according to the UK Living Well guidelines, if you are in the top 10% of society, on the far right, you spend about 6% of your monthly income eating a healthy diet. If you are in the bottom 10% of society, you have to spend up to 74% of your monthly income eating a healthy diet. So I dare say everyone in this room probably is going to continue to get even healthier, but a big chunk of society is going to be struggling. And if COVID taught us anything, is that unless the whole population is healthy, you can crash the entire healthcare system. Singapore was so fortunate that we had 500,000, 500,000 migrant workers in Singapore down with COVID around the same time. We were just so lucky that less than 0.0001% needed ICU care. Because if even 1% of them needed ICU care, we would not have enough ICU beds in Singapore. And we do not want to be in a position where the ICU doctor has to make a decision. Do I intubate the person working, digging up streets, or do I intubate the university professor? This is another example. Life expectancy can be dictated by which subway stop you get off when you go home. This is dramatic. This is from Chicago, where there's a 15-year difference between, say, Washington Park and the Loop. But this is in every country, in Singapore, in London. These are social determinants of health. The second concept is that health is an outcome of a complex system, and that is why it's so difficult. If you just look at obesity, obesity is not affected just by the quality and type of food, but employment opportunities, climate change, the level of public transport, air pollution, physical safety, urban design. All of these have to be involved if you want to tackle obesity. And this is a good example. The randomized trial was done where you lower the cost of healthy food by 50%, but the uptake is less than 5%. So it really requires a complex systems approach if we are to tackle this. And the third important concept is that health requires investments across the entire life course. If the man and the woman are not healthy at the start, the chances of the fetus being unhealthy already is higher. And if the fetus does not have if the mother does not have a good pregnancy, the chances of the fetus being affected goes up substantially. We've got a very nice cohort study in Singapore called Gusto, which has shown that children born to mothers who are under significant emotional stress, their amygdala is abnormal, the frontal cortex wiring is abnormal, and they have difficulty catching up, even up to high school. So it's really important that we invest in every course of life, from prior conception, pregnancy, early childhood, adolescence, adult, early, middle, and late stages of life. That's why we still vaccinate 80 and 90-year-olds against COVID, because prevention still works at every stage of life. So this is the WHO report, 3 components of healthy aging: functional ability, intrinsic capacity, and the environment. So functional ability, really getting people to remain functional throughout their life. So not only is it important to maintain an adequate standard of living throughout life, but to continue to learn, grow, and be involved in decision-making throughout life, to be mobile, to continue building relationships, and to being able to contribute to society. These are all critical if we want to seize the longevity dividend. Intrinsic capacity involves locomotive capacity, sensory capacity, vitality, cognition, and psychological capacity. And then the environment, the importance of the environment. So the NAM Global Roadmap, basically 5 principles: that people of all ages must reach their full potential, that societies can and must enable this, that we have to reduce disparities and enhance equity. We have to harness the human, financial, and social capital of all ages, especially older people, and especially in countries where there's age-based retirement. And that we have to use data. We have to use data and meaningful metrics to track whether we're on track. So 8 goals. So we need to have economic and social benefits generated so that we can generate the resources required for this to happen. That we need to restructure our social infrastructure, our institutions, and our business systems. Our current society is built for a life of 60. All policies were built when life expectancy was 60, not 85, not 90. We saw what happened with France when France tried to raise the retirement rate. But we need to do this. We need to look at education and training opportunities throughout life. Why do we only go to school from age of 6 to 25? No OECD university has more than 2% of their student population over the age of 40. But we talk about lifelong learning. And if COVID taught us anything, it's very hard to learn by Zoom, and it's very hard to learn by correspondence course. We have to go back to class. But yet, less than 2% of OECD universities have students enrolled over the age of 40. We need social cohesion. We need social protections and financial security. We need to ensure that our physical environment and infrastructure enables this. And we need to integrate public health, social services. We need to move from disease centricity, and I'm one of the biggest culprits, cancer, but really looking at the entire person, because my cancer patient very often has diabetes, has hypertension, has hyperlipidemia, may have had a stroke, has osteoporosis. How do we manage the person? And then very important, long-term care. Why do people have to go to nursing homes? Why can't people get long-term care at home, where their families, their friends, all their visual cues are in the environment that they're comfortable with? So this issue of quality long-term care, where people want it. Can we have quality care, long-term care, where people want it? Not, basically consigning people to nursing homes. So finally, 9 recommendations. We need to design the work environment to enable older people to remain in the workforce. We need to redesign education. We need to learn about the science of learning in older people. It's very different, the science of learning, when you're 20, when you're 75. we need to address ageism. Ageism is such a unique bias. You know, we have sexism, we have racism, but ageism is a bias against our future self. There's data to show that if you just send out a resume where the only difference is age, the callback for interviews drops by about 30%, just by adjusting the age. We need to ensure financial security for people throughout all ages, especially when people are older, because it's very hard to generate that kind of income when you're 75. We need to increase financial literacy. We need to get generations to appreciate the value of each other. So we need younger generations to appreciate the value of older generations, and equally important, older generations have to appreciate the value of younger generations. There was a nice randomized trial done by Axel Borsch-Supan, a German economist at the Max Planck Institute in Mercedes in 2016, when he asked the question, who can build better trucks? Now, building a Mercedes truck has lots of moving parts, and it's a big thing. A workforce of people in their 30s, or a workforce with people up to 65, because at that time, retirement age in Mercedes was 65. The bottom answer after 1 year was that the multi-generational team produced better trucks. Because the younger generation teams, the teams with mainly people in their 30s, very energetic, very fast, but when they ran into problems, got flustered more easily, and produced trucks with more defects. The multi-generational teams with younger and older people, they had the dynamism of the younger workforce, and they had the older workers saying, don't worry, I've seen that problem happen before, this is how we fix it. We need to look at our health systems, and we need to really invest in public health. Currently, about 2.4% of national healthcare expenditures go to public health. 2.4%. Canada leads the OECD at about 5.9%. But we all know the return on investment on public health, but yet we're spending about 2.4%, and 98% is going into looking after the sick, which we need to. We need to look after the sick, but as populations age, the number of sick is just going to increase. And we need to get healthcare systems to shift towards looking at this issue of the life course. And very importantly, we need to relook at how we develop long-term care. We need to encourage older workers, older adults to remain in the workforce. We need to look at redesigning education, science, and learning. We've talked about ageism, financial security, financial literacy, intergenerational communities, public health systems, and long-term care settings. So these are the key targets that we need to address. You can see this entire list. I'll be providing these slides to Peter, and so you can, but these are all from the National Academy report. So these are all the targets we have to work on. And why do healthcare systems like Semmelweis in Singapore, it's a National University Health System, because very often healthcare systems see the end result. We see the burden of disease. You know, the housing minister really doesn't see the burden of disease. The transport minister doesn't see it. Certainly the education minister doesn't see it. But the healthcare system sees it. So we need to get out there, but we cannot do this ourselves. We have no authority over these areas. But we have to show the data. We have to make the case and show that the evidence is out there. So this is the health impact pyramid, and you can see that I spend a lot of time persuading my patients to go for mammograms, stop smoking, go for their scopes, check their lipids. That's all the way at the top. And as you can see, a huge amount of effort is required as you go up the pyramid. The population impact is greatest when you hit the base. You know, Mike Bloomberg probably did. I think that Mike Bloomberg deserves a Nobel Prize in medicine because he was the first person to actually say no smoking in public restaurants or public areas in New York. No country, no city, even Singapore dare not do it because they were scared that it would collapse the restaurant industry. But Mike Bloomberg did that, and the cardiovascular death in the United States dropped by more than 50%. And I think that this is when you make the healthy choice the default choice, and when you impact socioeconomic factors, it has a huge impact. And there's very little individual effort required. So I think that we need to look at, certainly we need to constantly counsel people to go for age-appropriate screening, but we need to work at the base of the pyramid. And this is where I think we need to be at. So finally, this is probably the most important diagram that I'd like to share. This is the virtuous cycle of healthy longevity. So if we have a strong social compact at the center with equity and social cohesion, and I must share, when we looked at the English literature, we only found 2 countries which had their social compact on the internet, New Zealand and Singapore. Hungary, it may be in Hungarian, but the United Kingdom social compact has not been updated since David Cameron's prime ministership. We could not find the social compact declared by most countries. Canada did say that they are revising their social compact because it failed in Canada during COVID. An inordinate number of deaths in Canada occurred in the precariat, so their social compact failed. But if you have a strong social compact with equity and cohesion, and you invest in the bottom right-hand corner, the enablers, you invest in work, social capital, the physical environment, and health systems. And then you address the disruptors. You address ageism, you address disease, poverty, social determinants of health, pollution, climate change, conflict. You lead to populations and societies which are robust. And you can then seize the longevity dividend. And the longevity dividend is increased human capital. And the increased human capital is even greater than when women entered the workforce. Prior to the Second World War, women were not in the workforce at the degree as they are now. Now you look in medicine, more than half the workforce are women, and that's fantastic. But you can see that all countries boomed after women entered the workforce. And the same thing can happen if we can keep older people engaged and contributing. So not only is there just human capital, the social capital is enormous, and then the financial capital. Let me just share with you the financial capital, because you need money at the end of the day, and we need to persuade ministers of finance. So the UK have estimated that if you can increase 1 year of working life in the UK by 1 year, okay, you can increase GDP by more than 1.5%. David Bloom and economists at Harvard T.H. Chan School of Public Health, together with economists in Europe, looked at what is the economic output now. This was in 2020. Okay, so in 2020, what's the economic output of people over the age of 60? And it's 7.3% of GDP. Now, in Singapore, I helped contribute to the development of biomedical sciences as an industry in Singapore. The biomedical sciences contributes about 4% of Singapore's GDP. Older people, at least in the United States and in Europe, contribute 7.3% without any formal structures in place. Can you imagine what would happen if we had formal structures in place? And finally, Andrew Scott and other economists in the United Kingdom and the United States have looked at what is the economic value of increasing health-adjusted life expectancy by 1 year. And it's worth $37 trillion to the United States economy. And I'm reminded again that you need to spend $1 million every day for 3,000 years before you can spend 1 trillion. And you can generate 37 trillion by just shifting health-adjusted life expectancy by 1 year. So this is the virtuous cycle. You will generate the resources that can go back into the enablers, and you have to address the disruptors, and you can complete the virtuous cycle. Okay, 2024, April 12th. What do we do if we don't do anything? Well, if we don't do anything, we're going to have more people living with poor health, suffering, and dependence as populations age. We're going to lose all that human, social, and financial capital from older people. We're going to place increasing financial burden on younger people. There's going to be increasing financial burdens on government. They have to raise consumption taxes and other forms of taxes. They can't raise income tax because the tax base is shrinking. You'll have GDP that's lower than it could be, and most importantly, we'll lose opportunities for people of all ages, not just older people. So we need to reframe this dialogue that we're having. Okay, long-lived populations are not the problem. The problem is that we haven't addressed the barriers that prevent all ages, young, middle-aged, older people, from reaching their later years with the good health that they can very easily have so that they can continue contributing to family and society. And if we actually try to implement all the evidence that we do know, we can develop a resource that's never existed in human history, an age-diverse society that builds on the complementarity of the skills and qualities of both younger generations as well as older generations. So I actually spent quite a lot of time at Stanford, working with the Stanford Center of Longevity. I'm one of their senior academic advisors. And Stanford has this great question: why can't we relook at how we live life? This is how we currently live life. We put all our education from kindergarten to university with a small amount of leisure time. We then spend from 25 to 65 working like crazy. Maybe we take 2 weeks vacation every year. And then 65, 70 comes and we spend 25 years wondering, what are we going to do? That is how we've currently structured life. Why does it have to be that way? Why can't we have a blended life? Why can't we actually go to work much earlier, but then go back to school and reinvent ourselves? I mean, I've had to force myself to as I said, I went from tumor metastasis to cancer clinical trials to learning how to run healthcare systems, and now how to wake up Singapore and say, hey, you know, we've got this huge challenge, but huge opportunity that still awaits us. And then why can't we take mini sabbaticals throughout our life? You know, I think that sabbaticals must be one of the greatest privileges, but I have yet to take my first sabbatical. I was going to do my first sabbatical, and then SARS hit Singapore. I was going to take my second sabbatical, and then COVID hit Singapore. So I was told that maybe, you know, pandemics are likened to when I want to do a sabbatical. But we should look at a blended life and not this compartmentalized life that we currently have. So I fully agree with Rector Bella Merkley that, you know, health in man is like salt. It gives taste to food, because whoever has no health cannot savor any pleasure or delight. So thank you very much.
I'm pretty sure that the audience has multiple questions, so now it's high time to start the discussion part. Who has questions?
So that was incredibly interesting, and I was completely unaware of this as actually being important science. But I can see that you have a chance of making an impact in Singapore, because there's a lot of control, the government has a lot of control over what happens and a lot of interest in doing what's right. In the United States, we can't seem to get anything done in terms of legislation. Is there any hope?
Well, so Singapore, yes, the government has enormous influence, but even, I showed you the figures. We're doing terribly in Singapore. So this whole issue of implementation and behavioral science is so critical. And we are discovering that we have to co-design our strategies with the population. It's like everybody in this room. We cannot continue our exhortation that this is what people have to do. We have to show people that this is in their interest and that they will benefit from being involved in going back to school, in exercising, in financial security. And that's probably one of the biggest challenges. So I would say every country is struggling with this, at least in Singapore. So Peter knows this, Singapore has allowed us to take one township. So we have taken one township representative of Singapore, so I'll just briefly. So we have taken one township representative of Singapore, population of 100,000 people. It's already super aged, so it's going to be what the whole of Singapore is going to look like in 2026. 80% live in public housing, so the socioeconomic profile is similar to the whole of Singapore. And we're seeing whether we can shift the needle in these areas, where we're really saying, okay, can we bring in everything we know about science? Because we're getting all the academics and we're saying we're all so smart, how can we take all the science that we know and really implement this? And this whole issue of co-design is critical, with co-design with the residents and with stakeholders. So I understand Stanford has just secured a new community. They may be announcing it soon, and they're sort of saying maybe this is where they can at least pilot some of these areas. Last month I was in Cincinnati. So Cincinnati Children's is currently ranked #1 in the United States for Children's Medical Center. Cincinnati has been working on this for the last 14 years, on improving the health of all children, all 500,000 children in Cincinnati. They can't take on the adults because the adult side has not taken this on like the children. But there are pockets in the United States which are saying we can't wait for governments. We have to do this. And in Singapore, the same issue. You know, Singapore, we've had, the nice thing about Singapore is that they're willing to, Singapore has its social compact. They put out the report card every year. They've been investing money in all of these areas. And so we told the government, if you're investing in all these areas, why do we still see these big gaps? And at least the government likes, they act on evidence. We gave them the WHO report. We gave them the NAM report. NAM came to Singapore and shared the report. The cabinet came and listened. So we're trying to do this in Singapore. We have to. We have no choice. We have no resources except our people. So for us, it's an existential issue. We have to do it. And maybe if the United States realizes if countries around the world realize that this is an existential issue, then maybe they will say, let's get all the academics together and say, it's not just the biological sciences, but as you can see, a big chunk of this is social sciences, engineering sciences, environmental science, data science, and say, how can we bring the sciences together to bear on this? But that's why it's so difficult and no one's been able to do it. G proteins are far more elegant.
Thank you. Other questions? Yeah,
yes,
we have
please.
one.
Okay, let's say it like this. So, thank you for your inspiring talk. My question would be that what can we do as simple healthcare workers, as most of us want to have the power to dictate policy to make the big changes in society? What can we do as individuals in our individual life, in our healthcare work, in our research? What is our possibility to change this area?
Well, I still see patients. I was a healthcare worker also. And I think Ignaz Semmelweis was a healthcare worker also. So I really do think that what we need to do is organize ourselves. We need to say, this is what the science tells us, and this is what the data tells us. How can we organize ourselves? And that's what I've been spending the last 15 years ever since I was dean of the medical school, for the last 20 years, I've been trying to organize, firstly, the university, the healthcare system, and then making the case, showing the evidence. I mean, the Singapore government won't do something just because John Wong thinks that this is a great thing to do. But if you show the science, and you show that this is what the world is thinking and talking, and you bring in international faculty, I mean, we've been very fortunate. We've had tremendous support from the international faculty. Oh, okay, I didn't list them. We've got tremendous support from the international faculty to show that the science and the knowledge is there, but it's really difficult. So I think that it all starts off with people who see the cost of inaction. And I dare say it's the healthcare system that sees the cost of inaction. As I said, the housing minister doesn't see the problems that the healthcare system sees. So we need to organize ourselves, and we need to cut across all disciplines. So I work very closely with the social sciences, with the engineering sciences, computing, anthropologists, economists, because everyone has a piece of the puzzle. But we all need to get together. And I think this is one of our contributions as academics. I mean, Semmelweis University has been here much longer than any government. And the same for Singapore. Our national university in Singapore existed when we were a British colony. So I think it's our job to say, how do we want society to look like for our children, our grandchildren, especially when we know that the evidence is there. And I think that I just tell people, we should not say I'm just a doctor, or I'm just a nurse, or I'm just a pharmacist. We're a person with great training, with great knowledge, with great insight. We have to organize ourselves and actually get like-minded people to work together to address this. Thank you.
Very nice presentation. Thank you very much. You mentioned that you are seeing younger and younger people with diseases which were used to be relatively restricted to the older generations. My question is, what's the reason? Is it because we have better diagnosis? Or is it because we have pollution? Or what is the cause? Something is degrading, or right. Is it a sign of an improvement, or because the diagnosis is better, or a sign of a degradation? Thank you.
Excuse me. So let me start off by saying I don't think it's because we've got better diagnosis. I think it's there are several factors in the environment that have triggered this. Probably the most preventable in this are going to be alcohol and obesity. The level of alcohol intake, we know alcohol is a carcinogen, and the fact that people are just drinking much more at younger ages is something we need to do something about, because we're exposing people to carcinogens which they never were exposed to before. Yeah. So alcohol, I think, is a big driving factor. The second is obesity. Multiple cancer organizations have said that after tobacco, the three most preventable causes of smoking, of cancer are tobacco, alcohol, and obesity. With obesity, cytokine generation goes up. There's definitely increased cytokines. I mean, fat is not inert. It's a dynamic complex system. There's constant release of cytokines, and that's damaging DNA. And then this issue of we know that alcohol is a carcinogen also. Then we don't know the effect of microplastics. I mean, it's stunning. In every bottled water, there are a few 100,000 microplastic particles, and whether that's what I didn't show is, I mean, we saw global fertility rates drop by 50%. The quality of sperm in men has dropped by 50%. And is this because of microplastics? It's very possible. I mean, we've consumed so much microplastics, and my understanding is that the organic chemistry of plastics has similarities to estrogen. So again, whether you're going to see challenges like that. And then we have not talked about mobile phones and the profound effect that social media has had on mental health. I mean, my understanding is that schools in the United States have banned the use of mobile phones, and they've seen adolescent health improve after they banned mobile phones. So I think this is where we really do need to take science and say how, we can't let this experiment go on and destroy entire generations. Yes.
Thank you very much for the very inspirational speech. I grew up in Singapore and I spent over a decade there. And as a Hungarian, I think one of the biggest differences is that people in Singapore are a lot better at visiting the doctor out of preventative measures. So I think people here, I think there's a sense of we wait till there's a serious problem until we actually seek help or seek treatment. What do you think is the biggest difference, and how can we encourage people here to seek medical help and treatment out of preventative needs rather than waiting until the last moment?
I need to find out where you were staying in Singapore, because in the township that I'm working, a large number of people do not seek preventive care for two reasons. The younger generations tell me they're just too busy. The older generations are financially insecure. And when you are financially insecure, healthcare is the last priority. Your first priority is making sure you can pay electricity and water bills, putting food on the table. And so a great number of our people aren't going for their preventive health in Singapore because of those issues. And that's why we think that financial security is the key to the lock in Singapore. I mean, in Hungary, I think we need, all countries, it's going to be multiple. Firstly, we have to increase health literacy. People have to understand that you can't expect to abuse the system and then expect everything to work perfectly when we want to enjoy our older age. And then there are the social determinants. People may want to look after themselves, but if I have to spend 74% of my income trying to eat a healthy diet, there's no way that's going to be possible. So it's a very difficult issue. I mean, but we can't force people to go for their checkups. We have to show them that it's worth their while, and we have to show society that it's worth. So the employer must say my workforce is aging. I want my employees to go for their checkups. Because when an employee goes for a checkup, sometimes it's half a day from work. And then you don't want the employer to scold the person, why'd you take half a day off to go for your mammogram or your scope? So employers have to understand that we'll never have the kind of young workforce that we used to have before. So everyone has to be in this together. And I can share that Hungary's challenges are Singapore's challenges also. Yeah, but maybe you can, if you tell me where you were staying, I can understand maybe you were staying in a very enlightened community. Thank you.
Further questions? Maybe I will take the next one. So highlighted that the good health generally consists of mental, physical, and social well-being. Can you just mention some specific steps, actions done by the government or policymakers in Singapore in order to improve these either mental or well-being?
Well, I think that in Singapore, I would probably say that one of the biggest things that Singapore has been able to do was to say, okay, we will have a social compact, and publicly declared. So Singapore, you can Google Singapore Social Compact and it'll be brought to this website. And there are the 6 areas that Singapore wants equity. Education. So the best schools in Singapore are the public schools. Employment. Healthcare. So there's no public hospital in Singapore that I would not go to in an emergency. Housing. 80% of Singaporeans live in public housing, and 90 own their own apartment. So, when I retire, I want to move into public housing because it's got all the amenities there. And then retirement and social and community assistance. And every year, Singapore, the Ministry of Finance publishes the Singapore Public Outcomes Results, SPOR. So every year, the public report card goes out of where Singapore sits in these 6 areas. What's the gap? Now, I just want to say, okay, this is fantastic, but we need now to translate this all the way to the ground. And this is what Singapore is investing in. There are 12 areas that Singapore is investing: workplace, learning, volunteerism, health and wellness, retirement adequacy, social inclusion, protection of vulnerable elderly, healthcare, housing, transport, public spaces, and research. But again, you need everyone getting together. The government alone cannot do this, as the data shows. It requires, I think that the academic community needs to respond to what governments are trying to do. We can't just leave it to the government. And to me, that's the beauty of the United States. The United States is remarkable because they say, we're not waiting for government, we're going to do it. Yes, please.
Okay, we have one question there.
In one of your slides, you showed that there is when the price of healthy food was reduced and it was purchased like 5% increase. So my question is there any data that shows that like people know what is healthy food? Because sometimes it's really hard to know what is a healthy food, like if I want to cook and yeah.
So the answer was that yes, people did know what healthy food, because that was what they were. This is the data. Okay, so they basically subsidized the cost of fruit and fresh vegetables. So they lowered the cost by 50%, but the uptake was less than 5%. So if you spend your whole life eating high fat, high sugar, high salt, fast foods, and I suddenly give a fresh salad with olive oil and balsamic vinegar, less than 5% said I enjoy that meal. So that's the challenge that we face. And so even, as I said, following healthy eating guidelines is not enough. Thank you.